open this new session of ATHS 2019 with this logo and this international component. We have a very interesting subject, even if for some of you it's over. Some of you think that hepatitis can be cured, so therefore it's not as important, not as challenging. From what we hear, it seems that everything is fine. We don't need to get mobilized. This is not really the case. We had two major events recently. The day on viral hepatitis a few weeks ago in Paris, and the issue in Montreal. As you know, it brings together all specialists in the treatment of drug addicts, mainly from Canada and Australia, but it's a very high quality. And François BAILLY and Karine LACOMBE were there, so they will tell us what you could hear there. We are, it's in late 2013, we saw the direct antivirals. We know it works, but there's still some work to be done. There is a new survey, a new study with blotting paper that François will tell us about, but this study is limited, but it gives you unexpected information. All of a sudden, half of the infected patients disappeared in the woods. I can be ironical because the trust interval, the confidence interval is very wide. Since it was voluntary, the respondents are more inserted in society than the others. And the TROD study shows that when you do advanced screening, we are really surprised, and you find, even in non-migrants, among our neighbors, we find a major prevalence for hepatitis C. So there is still work to be done, and France has made progress. We did good work. You know why? Because of the original sin. So we live with this concept, this basic concept of the original sin. This is why we are stimulated, and we have to continue. It's possible because there are still 100,000 people to be treated. We can treat 15 to 20,000 per year. In 2025, we need to have to cover all 100,000. It's possible, and we don't have financial problems in France. How much did it cost for the 60,000 patients we treated? How much? 3.5 billion. I took my calculator. They say, oh, it's not expensive. Don't look at the individual price. But we have retro commissions. I'm using inadequate words, and therefore the total figure is less. I was disappointed because 3.5 billion, if I calculate, it's 60,000 euros per treatment. The production cost of treatment is less than 200 euros. In poor countries, the price of a cure is 200 euros or even less if you negotiate. And we paid 50,000, so we are rich. So we're not going to hesitate. We're going to complete the job, and we're going to win together Our speakers are going to tell us about what I'm suggesting. We still don't have a moderator. He's lost in traffic. So I'm going to call François BAILLY, who's going to tell us about the epidemiological situation in Canada, France, Australia. Thank you. Thank you, Mr. TREPO. Thank you for inviting me to participate in this meeting. Let's start with epidemiological data. To begin with, let me give you a couple of tell you a couple of things to understand the stakes in terms of screening. Hepatitis C is currently we have a very heterogeneous population of patients. At first, it was after World War II. There was a peak of transfusion in the 70s to 80s. Then the drug users they come after, and all this population, because of the history of hepatitis C, is going to accumulate. Therefore, we talk about reservoir. It becomes chronic in 70% of the case. So this reservoir has different ages, and it's going to develop differently in time. So 30, 40 years later, we have a population that is aging. Those who had the transfusion before 1990 are 70, 80 years old, and some of them are going to die with hepatitis C. And the drug users, they are not that young. He's no longer 18. They're mostly 50 or more. So this population is aging, and this heterogeneous situation with the new contaminations from migrants. Therefore, it's difficult to conduct epidemiological surveys and to have screening strategies. What changes our vision is the new treatments. We had epidemiological recent data with the objective to eliminate the. What questions can we, what are the questions? Where do we stand in 2018? How many subjects are infected? How many patients were treated? How many subjects to be screened? And what is left to be done? The epidemiological data in France are old. I wrote historical data, but they were the only data we had. This is a study from 2004 that was revisited, and the data we had were published in 2016 based on 2011 data. At the time, you said there was zero prevalence at first, and then RNA HCV prevalence of 0.42%. We no longer talk about zero prevalence, but only patients with positive ARN. At the time, we identified this high-risk population with three major groups: drug users, people transfused before 1992, migrants, and the rest. We didn't know how they were contaminated. So this data, the data were recently published, so methodology is different. This study is part of a major telephone survey. It's a random sample of the population by telephone, population 15 to 70 years, 75 years of age. So it's HIV, HCV, and high-risk populations. Within these participants were offered blotting paper screening by mail. So patients are insured, they are over 18 years of age, they receive a letter, they put a drop of blood on the blotting paper, and they send back the paper. So you see the methodology selects people who have an address, who can answer a mail, that can withdraw the drop of blood. So this is a general population, but which is already selected. So the results of the survey, these are, you see, it's 20,000 people were interviewed, 17,000 are offered to do the test, and 7,000 people sent back the blotting paper. So in terms of prevalence, it's 0.30%, but it needs to be compared to the 0.42. So 0.3% of the population has HCV ARN. That's about 130,000 people. In the survey, among the people with tested positive, 80% already knew they were infected. So by extrapolation, so in France, there's still more than 25 people who are undiagnosed for hepatitis C. I mentioned hepatitis B because it's difficult to make a difference. The results show a decrease of hepatitis B because there is no treatment and history has not changed. But this raises the problem of methodology of the study. We have the same prevalence for both hepatitis, which is doubtful. If we focus on hepatitis C, 0.3% of the population prevalence, more men than women. The age of the population is mostly people over 40 years of age. The group of patients had a transfusion before 1992, and the risk related to drug users, 12% prevalence. What about the development? What is the development of that prevalence? These are the models based on the data available. We started in 2004, over 200,000 people, and now it's about 130,000 people. And what comes as a surprise is the major increase of people who know their status. This is so when we survey people who are have a medical treatment, they know their status. Another major data is the estimation of the incidence. The prevalence data are complex. Incidence is even worse. You see the estimation is in the general population with low risk is 50,000 new cases per year, and two groups which are the source of new infections, if we exclude the migrants, is the drug users, less than 5,000 new infections per year, and HSH, the men having sex with men, with European epidemics of acute hepatitis C. The total figure is about 5,500 new chronic infections per year. And finally, the estimation of hepatitis C as of January the 1st, 2019, if we take into account the new patients, those who died, new infections, we have no data on migrants. It's about 100,000 people with a chronic hepatitis C. So we can talk about this figure. Regardless, even if we underestimate the number of infected patients, there's still some work to be done, and we have a mission. A few words about the specific populations. Since we've been studying hepatitis C, we try to know more about about the specific populations. On the circle, this comes from the hepatitis C surveys and the data. We had 4 major groups: the drug users, with data of seroprevalence that was major, the migrants, people in jail, and co-infection. If we look at this data, what happens in terms of prevalence among drug users, seroprevalence, which is estimated according to the Coquelicot survey, is about 30% of drug users that have hepatitis C. This is very heterogeneous. Among homosexual populations, male population, it's less, but it's directly related to their practices with the over-risk involved in slum and chemsex. We have a few data among the migrant populations, and in the past consultations, you see that the knowledge of the serological status in the population is globally low, even if it's higher among active drug users. It's less than 50%. Many of them have already been screened, which is not the case among migrant populations. Do we know more with the study? We don't know anymore, because the survey is not looking at these populations. We have data for drug users and over risk when there is an IV use. But what doesn't appear here, whether any precarious populations in the study, we don't know. And finally, tattoos and piercing are associated with an over-risk, but no information on specific populations. Drug users, we still have the Coquelicot data. This survey is going to be renewed in 2020, and they will give us a better idea about the situation, which has changed among drug users. With a new element is that there's still it's very heterogeneous and it changes very fast. How do we go back? Can we go backward? I gave you the experience of a XAPA in our hospital, where the patients are screened and have access to treatment, and the prevalence went from less than 20% in 2013, and now it's less than 2%. And this it's not because we're better, but the environment is favorable. So it can change very quickly. I'm sure that in other XAPAs we can have a very different situation. So the situation is fluctuating depending on, and it can change very quickly. The second high-risk population is the co-infected patients. Things are more simple now. This is this data includes many centers based on the NADIS software. We look at the HCV status among patients. You see in late 2016, and things have changed since then. In light blue, cured patients, orange, amber, people treated, patients treated and cured, So 82% of HIV patients are either cured or were treated for their hepatitis C. We know in 2016 we have a wider access to antiviral agents. So we can consider that in these HIV patients that are treated, the prevalence of hepatitis C is very low. There are still problems in the population. This is the other element we mentioned. We've seen in the past few years microepidemics of acute hepatitis C in many European cities with specific clusters. It's the same viruses, and acute hepatitis C, patients can have several, and they're related to injection or high-risk sexual practices, slum, chemsex, and invasive sexual practices, and it has increased among HIV patients. And we've seen non-HIV patients with acute hepatitis C. It's the same viruses, and this increase. And now it's going down. In 2018, it's much lower, and we have much less cases now. So this is being addressed. Other populations where we have even less data is precarious population and migrant populations. Many both elements are relevant when we talk about screening. You see here can we go backwards, please? On this slide, you see the percentage of seropositive for HIV is over 8%. Many didn't come to get the results. They are screened, but they need to be informed about the results. And the associated parameters, the country of origin, overrepresentation of men, and knowledge of the status, which is very low in these populations. What's important is migration. These are the results of what we do in Lyon in terms of screening in asylum centers. These are last year's data. Over 900 patients were contacted. If we look at the HCV results, there is the precariousness, even in the non-migrant population, is associated to the high prevalence of HCV. So these precarious populations that are homeless in asylum centers, they have a high risk. And last point, this is not reported. It's what we call the forgotten reservoir. The left out reservoir is the psychiatric population. This is a Swedish survey where they screened the whole population, and a high prevalence of hepatitis C in the psychiatric population, over 4.5% prevalence. This is a major issue. And talking about screening, there is a major issue to address these populations, whether among inpatients or outpatients. So the field is open, and this is a major. Reinfections, you know there are reinfections. I have two major messages reinfection does exist. The highest risk is among co-infected patients. Intermediate risk is among drug users. And the challenge is why retreat the I have done it twice. Do we need to be treated again? I think there are two strong arguments. The patients, this is the prevalence, this is a British Columbia study, and the associated factors. What we see is the reinfected patients are the high-risk populations. If the patient is reinfected, it's because he has a high-risk behavior. So they need to be treated again. So the strategy is to say any recontamination must be treated immediately because it will be the source of new contamination. Besides any moral or ethical questioning, they need to be retreated. And finally, a few words about screening. This is we will hear about that later. The estimation is there about 100,000 patients to be treated. You see over the years the situation changes according to the access to new medication. It's decreasing now because a major part of the reservoir was treated, so we need to get new patients. What is the population to be screened? We have a high risk, we have risk populations. They need to be screened. We need to do that. The question is the others. How do we find the other patients who don't have, it's not obvious that they have a risk, and this is an issue. Universal screening has been proposed for everybody once with 3 viruses, probably at 50 years of age or around that, and the study showed that it was quite efficient. So it was recommended at one time by the scientific reports, but it was never recommended, and it's not going to be done. If we look at the strategy, there's still work to be done. In the barometer study, you see the screening, previous screening among the population. If there is no risk factor, very few had access to screening before it was proposed to them. Even among the population who received the transfusion before 1992, we know it's a population at risk, and only 20% of the population was screened. Some of the patients do not know they had received the transfusion. Finally, screening recommendations in France. At first, high-risk population cytolysis. The specialists said we need to screen the other viruses at the same time. It must be done at least once for all men and among pregnant women. In 2016, we mentioned universal combined screening, and at ATHS we mentioned this strategy, the study I talked about, and they considered that today universal screening is not necessary, and it's better to target risk populations, and this being associated with a harm reduction strategy. In a population where we treat addict patients, what can we do with these conclusions? Things are simple, I think. For us, we need to screen all our patients. a patient who is in a group situation with a migrant or precarious or drug user must be screened for all three viruses. So we need to have the resources for that, and we need to have imagination. If we don't have resources, we need to use new methods, new strategies, but we need to be innovative and imaginative. We need the addictologists know these populations the best, and they have to do the work. And finally, we need to re-screen our patients. This is very important, not only because of reinfections. We need to screen those, but also because many patients that are screened were already screened and were never treated. And re-screening is a boost for treatment. So we must screen all patients. Finally, there is a decrease in the prevalence in the general population, but we don't know what happens in specific populations. There are at least 25,000 people still to be screened. We don't have much data among the high-risk populations. The prevalence data are very partial. So the single screening strategy is not to be recommended because of the population is very heterogeneous. Do we very clearly we prefer to optimize a very specific screening with a combined screening of for all three viruses among the high-risk populations, among drug users, and any screening strategy needs to think about the follow-up. After the screening, the patient needs to get the results and needs to be treated. Thank you for your attention.
Merci, François.
Thank you, François, for this very nice background information, which also asks the right questions. Now, to start the discussion, so you discuss screening and re-screening. So you're right, people sometimes forget that they were in an at-risk situation. Now, the risk to be reinfected, except for the MSM, the risk of reinfection is low, right? Well, those are, when I'm talking about re-screening, once again, there are two meanings to this. First, we need to be aware that there are populations at risk that may be reinfected. People who continue to use and inject drugs should be screened every year. This seems to, this is a given. Now, the interest of re-screening in people who were screened a long time ago and were not treated. This is what we see in treatment centers or in housing facilities. So we propose the rapid diagnosis tests, and when we do that, they say, well, I know that I'm virus positive, but they didn't have treatment for different reasons. And so the fact that you screen again is going to open another possibility for them, another option to be treated. And in the populations are at risk or in a precarious situation, we are able to find new patients. So this is really practice-oriented. Now, do you think that treated as many drug users as possible is going to reduce the risk of new contaminations? Do you think that prevention is really going to help, as it did with VIH? In case of in case of acute risk, for instance, in an MSM population, we decided to treat acute hepatitis C in those populations before we had the respective guidelines. So in HIV patients, as soon as hepatitis C was screened, we would start treatment. Now, it seems that the epidemic seems to be on the decline. It's probably not the only explanation. It is true that we also had prevention and a number of programs as well. But it seems that there are a number of measures that were efficient on that evolution. Now, obviously, if you have someone with an at-risk situation plus a high viral load, then we need to decrease the viral load as quickly as possible in order to avoid contaminations. Yeah, can we have a microphone for the lady? Hello. I'm the head of a XAPA, a treatment center, risk reduction about hepatitis C. For a long time, we were told that we were good for HIV, but for hepatitis C, it's more complicated. But I wanted to insist on the role of peers. So, as I said, the head of a user association. I'm a psychiatrist by training, and I'm shocked by the way we go about the whole thing. I would like that we are better at disclosing the status, at talking about the disease. There are many people in whom it's not really helpful to dose the serology plus reinfections, etc. So it's not the right way to go about this. So I think what could really change the ball game altogether is to embark people who were treated and are able to explain what happened to their friends in using words that are the right ones and brushing aside all the problems that we encountered with interferon treatment. And so we've implemented that sort of approach in Marseille, and we're rather successful. Well, thank you for this. This is a very practice-oriented and apparently very efficient solution. But then again, you need to have the right structure. You need to be highly motivated. And I think there are very few structures as good as yours. We do not have a type of structure in Lyon, for instance. Well, working with peers, I think, is important. Now, when we want to go through the, when we want to implement strategies of micro elimination, well, Karine, I didn't want to sit here with you because I arrived late. Now, François, you talked about screening, and in particular, the different strategies for screening that we have in France. Don't you think that they could be improved? Because it seems that the pathway is rather complicated. We start with a rapid screening test, then we go through a viral load assessment. What do you think about the tools that we have at our disposal? Don't you think that self-tests could be of an interest in some populations? Well, it's true that it did not mention all the new tools that we have. Well, there are two challenges to screening. Now, we have to screen the right population, conduct tests, and then we need to have those people come back to receive their results and start treatment. We have in the slides that I showed a number of people who do take the test but do not come back for their results and treatment. Now, we have a possibility to have a rapid diagnosis test. We can also have an RNA test, a rapid RNA test, but it's not that easy to implement. when we discuss the situation in Lisieux, I know that they do that with a mobile unit, and they realize that the PIDs, the drug users who come to be screened in that mobile unit, they don't even want to wait for 1 hour to get the results of their screening. So it's true that we need to simplify the technique. We need to also reduce the time frame between 2 appointments. However, if we want to make sure that they are treated, we need to create links. And so I think that screening is just the first step in the entire pathway. So we need to have the right relays, the right contact persons, so peers, people in the community, locally. We need to have the right measures in order to maintain contact with those people. So we do screening, and when we come back to propose a vaccine, then they're no longer in the same location. We're discussing here people, homeless people, for instance. I'm sorry, what the lady says can't be heard without a microphone. Now, Karine, you are, of course, warmly invited to sit here with us on the podium. Well, François, congratulations. Thank you very much. You did shed an interesting light on the subject. Now we are going to call in a stuntman. François found a new concept. Well, there's a play on word here which doesn't translate very well in English, but he's going to talk about the cascade of care. And cascade also means a stunt in English. But anyway, so I would like to thank the local organizing team for their courage and the fact that they continue and organize ATHS and organizing that at the same time as the Rugby World Cup is certainly it's not a minor feat. Now, it seems that my slides are going backwards, says the speaker. Now, those are my conflicts of interest with AbbVie, Gilead, MSD, and SOS Hepatitis, which is an association, thanks to which we try to change things in the field. So today we have to mourn universal screening. We all thought that we could do that. High-profile researchers told us from an epidemiological point of view that it was possible to have a universal screening. But then with the number of positive screening increasing, this is something that we can't no longer envisage. So we need to be more cost-effective. Hence, a number of questions that I'm going to ask on that slide. Now, is it possible to have universal treatment without universal screening? That was the first question. We also tried in some cities to have cities without hepatitis. For instance, we have a city in the south of France, Montpellier, where they are committed to completely eliminating hepatitis C. We wanted to have villages without hepatitis. We wanted to have cities or towns without hepatitis. So I also had one of my users giving me the example of having an entire block of houses without hepatitis. So we discussed that option. We also discussed micro eliminations. But if we want to have micro elimination, i.e. elimination on a smaller scale, then we need to have a macro awareness raising. This is the first disease for which we do not have a model. So we learn as we go. We learn as we have a better knowledge on epidemiology. The natural history of a disease is being changed on a regular basis. It is true that in the past, when we had a PID coming in, we knew that 9 out of them would have a viral load. Now, today, when we have a PID coming in with a viral load, we realize that they have been screened in the past and potentially treated. Also, the last point is that for most of the diseases that we were able to eliminate, we used vaccines. And for hepatitis C, we need to have a different model. We need to have a different avenue. We need to go through that without using only vaccination. So everybody is talking about the cascade of care. So when I hear the word cascade in French, what are you thinking about? Are you thinking about raging rivers, about mountain streams, about girls and boys having a party, about an advertisement for a shower gel? Are you thinking about risk-taking? Are you thinking about a river flowing downstreams? Now, what is a cascade? Is it that picture, or is it rather that? Because in French, cascade means a stunt and a stuntman. So today, are we still stuntmen? And will we be still stuntmen in 2020? Well, I'm not sure. I would like to propose other avenues. During the last INHSU in 2019, a conference on those different viruses, there were more than 34 presentations on this cascade of care. So I'm under the impression that we have those different pathways and we analyze the different steps and the different intermediate steps, but it seems that there are differences, major differences in between countries, and we do not have the overall picture, i.e. what the patient can do to be screened and be treated. I think that a cascade for a person is meaningless. Of course, are you going to have serology? Are you going to have PCR? Are you going to have a fibrology? Hence the interest of having a more customized, comprehensive approach. So, as I said, there are a lot of differences in between countries. Even the legislation is not the same. There are countries where they do not have buprenorphines. There are countries where they do not have syringe exchange programs. There are countries like Canada where you do not have the rapid orientation and diagnosing tests. There are situations where you need to have a mediator. So again, those pathways cannot be compared. What worked nicely in Canada, for instance, is not going to be transposed easily to France or another country. And for me, the right cascade would be the entire pathway from the mountain to the lake. Now, let's talk about an example. Iceland. We told that in Iceland, they were successful in eliminating hepatitis C. So they had 100 to 1,000 infected persons. So they screened the entire population. Of the 800 infected, they find 741, and they were successful in having all those people cured. And so Iceland is the first country able to say that they were successful in doing that. So congratulations, that's all very nice. However, we still have 15% of those people who were not cured. So they say that they eliminated the hepatitis C, but there are still 15 not cured. So you need to have a risk reduction program, because those 15 people in Iceland may be the reservoir from which the entire crisis may resume, the epidemics may resume. Now, another snapshot. This is the one on in the United States. We know that access to healthcare is one of the main obstacles to treatment, and access to treatment in the United States is today not very good. Only 10% of those people seeking treatment have an access, because the social rights are not the same. Those are the different screenings on 2 independent labs, and this is an assessment of the people who were screened and those with a negative RNA after treatment. So definitely this is not an enviable situation. Now, those are the results that will be presented today in Marseille during another conference, where they demonstrate an improvement in the care pathway of a care cascade of vulnerable patients in the Île-de-France region around Paris, where we see that from 488 patients, about 95% of them were screened and treated. And this is also the situation locally in this very region, in Dépister. And we see that from 593 participants, people who took the rapid diagnostic tests, we still have 7 who were not treated. Now, this is an estimate for the world situation. So, of about the 70,000 with HVC, about 20% are diagnosed and only 1.5% are treated. It seems to be a disease of poor people, and it's better to have that type of disease in a well-off or rich country, apparently. Now, those are the recommendations by the WHO, and the recommendations are provide a number of diagnosis solutions and discuss that we should reduce risks in order to avoid new contaminations. And I would like to reiterate what was showed by the WHO during the INHSC. They say that if you want to have a powerful approach, we need to have a strong risk reduction. So this was a survey which was presented by the WHO, 179 countries with drug users, 93 countries with syringe exchange programs, and 87 countries had an opiate addiction treatment, an OAT. Less than 16% of patients that we discussed were benefiting from that. Now, syringe exchange programs. The objective was to disseminate about 100 syringes per country per year, per patient per year, per person per year. And you see that Australia and the Nordic countries were successful in distributing those syringes. But you see that in a country like France, for instance, we were not successful in meeting that criteria. Now, on risk reductions, we are in the right slot, as it were, when about 40 people on 100 screened can benefit from an OAT, an opiate addiction treatment. Now, of course, you need to correlate both syringe exchange programs, but also access to care. There are very few countries that are successful in doing both things at the same pace. This is Australia and Austria, the Netherlands, Norway. France is somehow lagging behind, is still in the group where we're not successful in having the right coordination in the exchange dissemination and the risk reduction program. So all this to tell you that, of course, there's a treatment, but it's impossible to do a proper screening without risk reduction as well. Now, we should have a more comprehensive approach and not only think about screening. The entire cascade does comprise also recontaminations. We hear many teams saying, well, I've screened about 80% of my target population, and we've treated most of them. But in the 20% of people who were not screened, this is in that reservoir that you have the highest number of people with the virus. So we need to adapt our strategies to reach out to those people who most of the time are afraid, do not want to take the test. So in the future, we will find less and less positive persons. And that's all nice and well, because the screening moment is also a moment when you're going to disclose information, when you're going to inform people. Now, we no longer disclose the number of positive people that we found in screening. We explained that we've done, for example, 250 screenings, but we also discussed for 20 minutes for those people, and we explained how they can avoid recontamination. I think what is more important is not so much the number of screening tests that we conduct, but rather the information that we provide. Now, Those are the last figures that we have as of the 1st of August 2019. So it seems that we have less than 100,000 people that remain to be treated. In August, with the sales, extra sales of drugs that received the market authorization, we estimate on average about 94,000 people with hepatitis C in France. Now, there's still a lot of work to do. About 80% of those people would be aware of their status. This is not necessarily the impression that we get from the field. And again, this cascade of care. In 2017, we treated 18,000 people. And we thought, well, that's good. We're going strong. Now, who did you treat in 2017? Well, I think that you treated the people that you knew already had hepatitis C or failed a previous treatment. So most of the time, what we did in 2017, those were mostly recalls of failed treatments. In 2018, we treated 13,000 treatments. And in 2019, we hope that we'll reach 12,000 treatments. And so we are not treating enough patients because we're not good at finding the remaining 94,000 patients. Are we going to accept, as we did in Iceland, that 15 people are going to be left untreated? And when are we going to stop? Are we going to say, well, there are 20,000 people who are not treated? Oh, that's fine. We're going to stop there. So we're being told, well, by 2022, we will treat 50,000 more people. And that's all very nice and well. But it is only halfway through when we think about the 100,000 patients who remain to be treated. Now, what are we missing? And what's missing? We need a new prevalence study. We haven't had a prevalence study since 2004, so because decision-making is based on such studies. We should implement compulsory declaration for acute hepatitis C. This is what they did with HIV. It does help, it does support decision makers, and maybe that would be a good idea to have a compulsory declaration. By 2020, we should think about the new natural history of the disease. We know that people are no longer contaminated in the same way in 2020 as they were 10 or 15 years ago. There are new contamination models. I'm thinking about MSM, people doing slam, people exchanging syringes during sex, exchanging blood. We need to think about also those new contamination models. We need to implement the new diagnosis tests, the new multi-tests as well. And we also need new concepts because we continue and think in the same way we did 20 years ago. I think that we could go about this in a different way. We should maintain a targeted screening. I think universal screening is not something that is feasible. We should also screen all 3 viruses at least once in a lifetime. We should no longer look at addicts being the only reservoir. So I would like to propose a new concept. I would like to introduce you to fly fishing. A fly fisher is a different type of fisher. We should become, as addiction addicts, we should mingle with the addicts. So we're not discussing about the people who come to the XAPAs. We are amongst them. And at some point, the fly fisher, you can hardly see them. What you see is the river, is the forest. So fly fishing is interesting. Why is that? Because it's different from trawl fishing. So you're not fishing all the fishes in the sea and removing all corals. You're targeting fishes. And you can fish different types of fishes. Trout. Are you going to fish one type of fish, a smaller fish, a bigger fish. I'm going to screen a drug addict, someone with a precarious situation, a homeless person. You can do this in different places. So are you going to fish in a squat? Are you going to fish in a home? Are you going to fish in jail? And you're going to have different strategies depending on the environment. And of course, the fly fisher knows how they are going to get the type of fish they're looking for. So you need to know the place, you need to know the fish. And you do not fish, it's not based on chance. You know that there are places, you know from word of mouth, where people are afraid. And again, we should adapt the bait, or we should adapt the fly according to what you want to find. Again, FibroScan is of interest for people with a concomitant alcohol abuse, because we try to raise awareness on the status of their liver. Again, when we think about fly fishing, they use those type of words. They use fishing upstreams, which means, well, we need to find those patients who contaminated all the others downstreams. And also downstreams is going towards what happens after they've been treated. So again, this is follow-up on cirrhosis, this is follow-up on non-contamination. We also have a no-kill approach. So when you get the fish, you then release them, you put them back into the stream. So you don't put them in jail, you don't kill them. And also, wading is a word that they use in fly fishing. There's one with those high boots, and so they literally walk in the river because they are trying to follow the stream. So this is what we should do as addiction specialists. We should go in there. And so fly fishing is much more than fishing. It's a philosophy. And I think that you should aim at becoming a fly fisher. You shouldn't be afraid of walking in the river and trying to better understand your fishes. And so we should have our own targeted therapies. We need to have a micro or nano type of screening. And there are groups we know are difficult and quite particular. And so the co-infected, the people with HIV, the people doing slam, the people in jail, people who are cured, and social networks are interesting. Look, I'm going to give you an example. It dates back 5 days ago. You read that on the social network. I participated to a treatment for hepatitis C in 2013, but I was not a respondent because I also have HIV. Today, there is no treatment for HIV people who also have hepatitis C. And we had someone from our network, SOS Hepatitis, answering, no, it's not true. There are treatments for HIV. And then you have someone saying, well, I'm waiting for a vaccine because I can't swallow the pills. So in a matter of a few minutes, you see this dialogue on social networks discussing misconceptions and preconceptions on hepatitis C. So you have to you have to do that listening on social networks, and there's a lot of work to be performed. So it's a work for activists, it's a work for peers who we need to train so that they become experts and they disseminate the right information. Now, there are recommendations. We estimate that there are about 4.4% of people who were previously treated and cured and are recommended. So this is one patient in 25 in a center where we conducted this assessment. So what is the sort of message that we should disseminate so that they reduce their risks? Well, we need to adapt this message to reduce also the risk of recontamination. Now, we decided that there's still a lot of work. We need to raise awareness in the general population. So we have a number of campaigns. We try to also raise awareness of the population on the health of the liver, how to care for your liver, and also remove the stigma around hepatitis C. Now, I would like to show you this is a sort of this is a teaser on a clip which will be broadcasted on the networks next week. So we traveled in the country and we shot that film, and this is what I would like to show you because it's very interesting. Hepatitis C is transmitted through blood. Yeah, but it's French, so I need to translate. So today we cure hepatitis C. So we need to raise awareness. This is why we toured the entire country, and we took advantage of 12 million people following the Tour de France cycling. So this was a good opportunity to meet with you, to inform you on hepatitis C. And to do that, we built a truck which makes a lot of noise so that you could hear us, and you did hear, and so you made some noise, you sung, and you provided with encouragement to help and support us. Thanks to you, together we made a lot of noise against hepatitis 2, 4,000 decibels. So it is the same level of noise that you have when a rocket flies off. So it's now your turn to be screened so that we are successful in eliminating hepatitis C. Thank you.
Bravo, Pascal.
Congratulations, Pascal. That was really excellent. We have to accelerate now, because we're on the road now. Questions for Pascal, and then we'll continue. Any urgent questions for Pascal? Your concept of fly fishing is really fantastic. You have to act quickly. So excellent, that concept was magnificent. So let's continue now. I'm listening to our organizer, and we're going to go to Barcelona now. And Joan COLOM is a specialist in public health. He's going to give us some ideas about public health of a great country that is Spain. Catalonia is also Spain. Yes, thank you very much. It is a pleasure to be here because I love this city, I love this country, and I love my friend Jean-Pierre and other people who've invited me every year to participate here in this meeting. I'm going to speak in Spanish now. There are a few people with the headsets, but I don't know if you all will understand me. But you can get headsets if you have time. You can get your headsets, and please, I apologize for not being able to continue in French, but I'm going to try and explain our experience. It is an experience in the Spanish state, but as you know, we have exclusive responsibilities in each region, and I will tell you the specific experience that we have in the region of Catalonia. As the WHO says, annual mortality rate is still, with hepatitis, it's one of the biggest. It is the second cause of mortality among these classic illnesses like tuberculosis, HIV, and malaria. And if we look at the number of people that have been affected, there are 71 million people that have been affected around the world. And particularly in our region is one. I will go quickly because we have less time now. And if we look at the prevalence in Spain, we can see that we have some specific data. There's a prevalence study published in 2019. It's very recent. Was done in blood analysis in primary care Here you can see the total prevalence of antibodies of the population of 20 to 88 years of age is 0.85, and positive chronic infection is 0.22, and significantly more among men than women. If we look at the age group, and this can explain why to do universal screening or not, you can see that the group of men of 50 to age 59 is the biggest. And under 40, the prevalence is very low. So we have to bear in mind that these kinds of studies does not have a hidden population. It talks about conventional and general populations who go to primary health care. In Catalonia, we also had a recent study by a Catalan hepatologist, and with our support, she did research in primary care centers to look at prevalence in Catalonia, not by a population that visits the centers, but by corresponding population groups. And in this case, there are 7.5 million people in Catalonia. We have approximately a prevalence of 1.1% of the population, with a presence of viremia of 0.47, and also 20% of these people do not realize that they are infected. We also made a mortality study to see the number one causes of mortality in the population. And indeed, hepatitis C is one of the 15 first causes of attributable mortality. And if we look the strategy of the World Health Organization talks about eliminating and not eradicate. I think that's very important. To eradicate, you can only eradicate with a vaccine. Eliminate or eliminating can be achieved, and they talk about a final goal of 2030. But to get there, with their concept of eliminating, means reducing the incidence or cases by 90%, and that. In order to do that, you need much before that, in 2020, to be able to diagnose 50% of the cases, to treat 75% of the tributaries, and virally suppress or cure 90% of them. And all of that by reducing the nosocomial infection and broaden the effort to cover the centers for harm reduction. Here you have the forecast by country. Spain is in a very good position after Iceland. Spain is one of the countries that has one of the best positions for eliminating hepatitis C, France, and then Italy. But for this, you need these four pillars: awareness and alliances in order to be able to mobilize resources. Secondly, policies based on evidence. And thirdly, to treat as a prevention and prevent the transmission. And then, of course, to increase the care and treatment services. And this is the number of people who have been treated up until now in all the different countries. As you can see, Spain is the country that has one of the highest rates of treatment, 16.13 per 10,000 inhabitants, and with the antiviral treatment, they've treated more than 130,000 people, and only in Catalonia here, 7.5 million population, we've treated 28,150 patients also since July 2019, with an expense of 323.4 million euros. And in the annual report, we have 5,605 people treated. In the assessment report, average age 56 years, 58% men, 42% with a sustained viral response, in other words, curing of 96.4%. We have a straightforward and well-tolerated treatment with a short duration, which is highly efficient. But for that, we've changed the paradigm. And I'm talking from the perspective of public health. I'm a doctor, but my specialty is public health. And the approach that we've done with hepatitis C in our environment has been an approach of public health. We've gone from 2014, 15, 16, based in more individual health and in treatment, to look at it now from a more collective perspective. That means preventing, treating and dealing with a chronic disease. That is a significant change to go from a more individualized treatment to a vision, a multidisciplinary, where hepatologists, microbiologists, infectologists, specialists in drug dependency, community entities, organizers of and associations of users all have an important role. And that is the change. That is the big change, the significant change. Here we have some countries that have got some very special policy, like Iceland, Georgia, Australia, together with Catalonia, if you allow me to say so also, and of course France and Scotland. France also, I think, with a very interesting element, and that is the possibility of being able to treat from primary care and for the follow-up to done by non-medical professionals. And in Catalonia, we've created a specific program dedicated to the hepatitis C virus, hepatitis in general, and to HIV and to the sexually transmitted diseases that I have the honor of directing at the moment. And we have passed a specific elimination plan by the government of Catalonia. And this plan has, as you can see, is very highly developed. There are 6 goals, general 47 specific goals, 131 actions, but I'm not going to go into detail about that, but I will tell you the 5 main pillars. The first one, what is the situation? What is the state of art? And here you can see the general population. I'm talking about Catalonia in these moments. The general population is 0.47 viremia, and so there's a prevalence of self-declared, self-reported in the MS study of 2.7% in immigrant people. This is a very important element for us. People from countries with a high prevalence. 7.1% have come from Eastern Europe. 3.1% are sub-Saharan, and 5% from India. These are the prevalences from these countries. People who inject drugs. We've studied this group. For us, the prevalence is very high. 65.8%, and viremia 48. Co-infected people with HIV, the antibody prevalence is 26%. First of all, and finally, at prisons, we also check jails, and this is our responsibility in Catalonia, and we are in a position to be able to say that we can eliminate hepatitis C. So by 2021, we have a prevalence of 4.9 right now, and a viremia of 2.7. So what are the 2 big goals? To reduce the incidences of new infections. In what groups? In very specific groups, but using the system that my colleague was talking about before, but using the system of fly fishing. In other words, among the people who inject drugs. This is very important to improve the implementation of the program of exchanges of syringe exchange. They have 30 in France per year per person. In Catalonia, we have 280. The average in Spain overall, but in Catalonia we have a huge policy for many years now, and we have almost 300 syringes per person per year. We freely distribute out 1 million syringes per year. We have 16 harm reduction centers. We have more than 2,000 trained users. Peer-to-peer since 2000, we have 8,000 people under treatment with opiate substitutes, and we have more than 4,000 people in the injection rooms that we have. That means that we can work in the nature, in the countryside, and wherever. And in jails, whenever a person goes into the jail, there's a screening of diseases and illnesses, and that allows us to see how that person is and to treat any reinfections, which is an important problem. And also, we have a liaison infirmary in order to be able to link with external specialists when somebody leaves prisons with men that practice sex with other men. We have we are experiencing a phenomenon which is called chemsex, and so we are giving information and raising awareness through the community entities. We have about 40 entities in Catalonia, many of which work with men who have sex with other men and with drugs and drug users. This is very important. In hidden infections, first of all, well, we've got diagnosis facilitation model, which is called the reflex test. That means that when a person has, in a blood analysis, has a positive antibody, automatically the lab, without asking for any information, does the RNA test, and so therefore that we know that he has got viremia, and the doctor from primary care comes and tells him, you have a patient who could be treated, and this goes to the hepatologist in the zone. So with one single operation, we detect the exact situation. The second problem, from there to recover all the patients who have a diagnosis before 2015. Many people had diagnosis of hepatitis C in hospitals or primary centers, but with antibodies. So what is the current situation? We know how many people we have, and we can retrieve those people. We've got a mechanism to be able to retrieve them. We've created a point of reference in each primary care center. Everyone has their point of reference for hepatitis C. And finally, we have specialized training for people who inject drugs with risk behavior. We've transferred all the pathology history to the centers. We've got into the countryside and and how we've done that. We've been offering the diagnosis so that so it is together with the treatment. It is done at the same center on site, and that facilitates that as total analysis through reflex, dry blood, and gen X-ray, and fast test of antibodies if there's no other option. But the two first are the most important, and we've got a protocol, a model of action for drugs users, for people who are screened in jails, in men who practice sex with other men, and with immigrants. We have a very significant pilot program. We go to their work meetings, we go to their areas of prayer and to their religious environments, and we suggest the possibility of having a diagnosis on site. We do it, and we give the treatment immediately. And this is a study with 500 Pakistanis, which is a significant population group in Barcelona. Another thing that is important is to coordinate and facilitate access to treatment. First of all, before somebody went to a drug dependency center, from there he was sent to a primary care center. From the primary care center, they did an analysis. Then he had to come back to get the analysis. If it was positive, then there was a viremia test, and if that was positive, they would call him to go to a hospital to be treated. But that's impossible, really. You lose 90% of the cases by doing it that way. So what we suggested now, well, we've eliminated 2 steps, and therefore the person who is in a drugs treatment center or in a center for harm reduction, injecting themselves in one of our hygienic injection centers, is diagnosed and is treated in 1 week in the same place, since the treatments are short at this moment in time, and all of those that we've initiated are in curing phase. And so it's possible to treat on site, to displace the team, the fibroscan, the pathology team, not just to center, but they can be taken to injection centers. And so we have these 3 models, but the model that we are suggesting is screening, diagnosis, and treatment at the same place. And obviously, there's a 5th point, which is very important, which is to improve the degree of awareness and general information. And I said, as the previous speaker, we commemorate the World Day for Hepatitis. We encourage screening days, and we have a lot of relationship with associations of hepatitis C affected people, family people, and a lot of support, therefore, to all the collaborative entities. I will finish now by talking about the cascade, but in the good sense, in the sense of the lake, of trying to monitor what is happening. And here, obviously, we have a lot of biases, but I have given you a potential guidance. If we were to consider the cases of viremia that we have in Catalonia, we would have 30,000 cases. Since we've treated 28,000, we may have almost treated everyone, but we're aware that those 30,000 perhaps do not reflect the total, because the most hidden populations who do not go to the primary care centers have not been properly screened. So I look at another figure, which is much more exaggerated, 52,800 people, which are from diagnosis that exists in the historical clinical history of some patients that we have access to. And that gives us a different proportion. The first case, we would be 93% of those who are treated. The others, otherwise, it would be just 53%, and we have 96.4% of a sustained viral charge. So, first of all, to summarize, eliminate hepatitis C as possible. In few cases in medicine or in health do we have the instruments to be able to actually cure an illness, and nowadays it is a problem. We think that it is also fundamental to have a perspective of public health, and that means that we have an integrative model where the stakeholders, the peers, the infectologists, hepatologists, specialist doctors, primary care people, health people, all the fabric of professionals work together. 4 key elements: to reduce the number of new infections. That means prevention, reduce the delay in diagnosis. So that means early detection, detecting hidden infections, and ensuring the provision of treatment with a special emphasis on the key population. It's not the idea of segregating or stigmatizing. The idea is to include, to help, and to make everyone equal. And without everybody's coordinated support, we think that this is important. This is a very typical picture of Catalonia. I don't know if you've ever seen this. This is what we call castells. These are like castles that are made with many people piling up on each other, and you can get a tower of human beings of 6 or 7 different levels, with people standing on each other's shoulders. And but without all the people below, you couldn't make the tower. And I remember in the AIDS Congress in Durban, Nelson Mandela said something that I think is very relevant. He said the quality of a society is measured in accordance with the dignity and the care with which it treats its most vulnerable people. Thank you very much. I think that is a wish from our group also.
Grazie. Nous l'a recommandé Arcade.
So we're going to carry on with micro-elimination of HCV with Karine LACOMBE. I hope I'm going to stick to my time because my presentation is quite long. Thank you. You're going to see that finally I realize that I'm going to talk about, I'm going to touch everything you heard this, so it's going to be like a summary of everything we heard this morning to have a micro-elimination of HCV. I'm going to remind you what you heard this morning. Viral hepatitis are very important in public health. Between 2000 and 2013, they're the 7th cause of death. Between 2000 and 2015, there is an increase of the death, even more than HIV and tuberculosis, but more than malaria. If we look at the viruses in Europe, mortality, hepatitis, it's due to hepatitis C. You see the proportion for each virus. In Europe, it's hepatitis V. This is the reason why the World Health Organization, for the first time in the agenda, they have they want to eliminate hepatitis B and C by 2030. Now they are direct antivirals with more access that are more accessible, and this has significantly improved the prognostic of the incidence of end-stage liver diseases. among co-infected patients, it's the case, and even with mono-infected patients. This is a Canadian study between 2003 and 12 and 13 and 17. For all ages, there is a significant decrease of the incidence of end-stage liver diseases. So there is when there is a new medication, you see the long-term impact on the disease. What's also very important, we've seen that with DAAs, the mortality related to HCV is similar to among co-infected patients, is the same as for mono-infected patients. So we are in a very dynamic era to eliminate a disease which is still dynamic, as you can see here, with a high incidence, 1.75 million new infections per year due to drug use and healthcare associated, for a global prevalence of 71 million infected individuals. The World Health Organization, WHO, has recommended or issued specific objectives in the reduction of the number of new infections and reduction of mortality. This is what we call programmatic objectives, and then each country must adapt that to its own context. You see the objectives here between 2015 and 30. When we look at the result, is to go from minus to 5% diagnostic to 90%. There is a long way to go, and 3 million people treated by 2020, with 80% of eligible people should be treated by 2030. These objectives are extremely ambitious. To reach these targets, what interventions? You can see here care and treatment in terms of harm reduction, diagnosis for HCV or treatment of HCV. In 2015, it's in dark brown, pink for the rest. We're still very far. This is the global situation in 2015. At the beginning of the implementation of the projects you've heard about, we were still very far from the diagnosis and treatment. There are many models for interventions. They are listed here with results that you can hear about in congresses. What you see here is that these efficient interventions are a care continuum. Screening with fly fishing, the comparison was very interesting. You have to be active everywhere. From the beginning of the care cascade, you need to go to the patients, screen them to bring them to treatment, and make sure that they are not reinfected. And the ultimate stage is when they're cured to monitor the patient. What is the impact of the incidence and prevalence of HCV among drug users in Montreal? This publication shows that you have to offer integrated treatment of hepatitis C if you want to have an impact on the incidence and the prevalence. You can see here, this is modeling, so to show what are the best models in terms of co-efficiency and impact on incidence and prevalence. This study shows that it's a combined scenario with several interventions. First of all, reduce the time for diagnosis and access to treatment. When a patient is infected before he's screened, there shouldn't be more than 6 months if you want to have an impact. Then after screening, the patient must be treated within 6 months. Then you need to reduce the lost lost in the study, lost to follow-up. The loss to follow-up rate can be very high, and this has a very negative impact on the incidence and prevalence. Of course, treatment for all at all stages of fibrosis, to have medication that is more than 80% efficient. In those situations, in this specific model of drug users in Montreal, which is very close to the models we can have in France, we're going to have an impact. What are the keys to eliminate hepatitis C? Screening strategies, pan-genotypical molecules, simplification of follow-up, prevent reinfection, political will to eliminate HCV. That's what we call micro-elimination. Innovative screening strategies, we talked about it with François. That's what we call to go from multiple visit to single visit. And why not have a test with you screen and you treat immediately? I'm going to go very fast. This is a concept of multiple visits. You test the presence of antibodies, then RNA, several visits, and at each point you have risk of having patients lost to follow-up. With a single visit, you use a diagnosis test that will show immediately the replication. There is a real active hepatitis. You treat, and then you provide counseling to reduce the risk of reinfection. So the system is much shorter. You optimize the screening strategies. Then, in the current screening strategies, you don't use a point of care, whether it's antibody or HCV RNA. We're still very lab-centered. This is a photograph of for drug user center with Médecins du Monde in Vietnam. This type of center in the community where you can have immediate screening. This is a decentralized model based on point of care. Then you have this centralized model. What's important is to be co-efficient. Depending on the different contexts in each country, a strategy will be more efficient, and you have to know which one. I talked about the point-of-care tools to test the HCV RNA. Now we have many machines, many different devices. You can see the GenExpert, the GenDrive, many others are being assessed. We even have a test that is cheaper than HCV RNA. It's the HCV core antigen. It's a big machine now. I'm showing here results of a comparative study with RNA in sub-Saharan Africa, because it's in those poor countries that we have most patients to be treated for hepatitis C. This could replace HCV RNA. The problem is that for the time being we must centralize the samples, but there are rapid tests to detect the core antigen, and the financing of the development is provided by FIND with the support of United. We need to explore new screening models. Machines are being developed to screen in 10 minutes hepatitis B and C and HIV, and another type of screening. It's the self-testing. It's very it can improve the relationship with the care. For hepatitis C, self-testing, you have antibodies, so the population has already been infected. So in this population, the self-test will not be efficient. However, if you want to screen patients who don't have a known risk, so thousands of patients that come to consultations when they are 50, 60, 70 years of age because they need a test before surgery, maybe this self-test can be interesting for these populations. The question is how someone with a positive self-test, how will that person react? Now we have sociological, psychosociological studies showing that self-tests are acceptable. So the global challenge is to go from multiple visit to one single visit. You test and treat, as we try to do with HIV. One essential point, maybe we haven't insisted on that enough, what we call the contact tracing. When you have a patient who is screened, you should notify all the injection partners, all the sexual partners, if you're talking about men having sex with men, to have this cross-linking to bring to care all those in contact with the infected patient. For hepatitis C, it's not being done enough in France. We start doing it with HIV, but we know there are ethical problems. But in England, in Australia, this principle of notification of the partners is essential and is now part of the screening policies. I talk about the first block. The second one, pangenotypical molecules. We know it works with drug users, even with those who continue injecting. So you must use these medications without in all situations. Someone from ASUD was here, but people from associations like ASUD can really help to treat drug users, even if they're still active injectors. More than efficiency is the access to antiviral agents. When access to DAA is provided, more than we have a real impact. That's what you see in red at the bottom. There's a real impact on the number of people, on the prevalence and incidence of hepatitis C. The third block is simplification of follow-up. To simplify, you shouldn't bring people to care, but take care to the infected people. This is where, like fly fishing, you need to go to where these at-risk populations are. And the key is task shifting, decentralization, and target population, to know the target population. I just want to show that care simplification should take into account the populations where you work. In this test where you assess to show the difference between a standard, the simplified arm, phone contact with patients during treatment. 12 weeks later, you see them, versus a standard follow-up where you see patients on a regular basis. You can see that SVR is very good, 95% among patients in the standard arm versus 92%, but still statistically there is a slight less, the simplified arm is slightly less efficient. If we look at the origin of this difference, is the loss to follow-up. Many people who are precarious, extreme simplifications can lead to dropout. So you can, simplification, yes, but watch out. Here, this is a simplified follow-up as recommended in France when you decentralize treatment, and we hope that more and more XAPA treatment centers and community centers can treat. You should, people should be informed and be able to, we should identify the people to whom you can propose a simplified follow-up. Another block is prevention of reinfection. To be reinfected, you need to have been treated successfully. More and more people are treated, so there's a risk of reinfection. The second key is people remain drug users, and MSM are still very much have a very high exposure, and high-risk subjects that keep on injecting without harm reduction. Of course, they will be exposed to reinfection. Here you see that we have the three keys: high prevalence, high-risk group, and high treatment rate. So you have reinfection. So you have to identify these patients that will be reinfected. The last block is a political will. Things have changed in France since 2013. First of all, universal access, intensification of prevention and screening actions, a model of treatment that is no longer centralized but deconcentrated. The politicians should say it. That's important because we need them to have the money to implement all these strategies. And finally, opening of direct antiviral agents accessible in pharmacies, and the more prescribers. Since May, any doctor can prescribe and direct antiviral agents. All this is going to lead to elimination of HCV. We see with these different models of micro-elimination in the high-risk populations will lead to macro-eliminations, and worldwide you see in this macro-elimination scenario, again, it's several interventions of micro-eliminations are going to work if we want to arrive to reach these three targets: less mortality, less incidence. This modeling shows that you need to improve the transfusion safety, harm reduction among drug users, access to DAAs after diagnosis, and last but not least, only this will make the difference between the yellow curve and the red curve is decentralized screening and decentralized treatment to act on mortality. Thank you for your attention. Wonderful, Karine. You've summarized everything. It's all the same in Catalonia, in France, and the image of the fly fishing will stay with us. So quick brainstorming, and our president is coming to listen to. We need to have a break. We started late, so let's have a brief exchange. One burning question. I have two burning questions. One here. I'm surprised. I thought that Pascal MELIN would talk about turning over desks. I found a Paul Newman talking about a river. The questions over the last 15 years are always the same. We showed that that doing a one visit consultation works. With my first in a XAPA, in one place you can treat the drug addicts. You can write a prescription. With one sampling, you can have the whole range to RNA. So we could do everything at the same place. You're all very optimistic this morning. I'm very happy, but this XAPA is a fragile structure. The retests being done in high-risk populations, I think this is no good. Access to care is not as good today. In the hospital, when I do a diagnosis, maybe this development, I do a CGID or anti-tuberculosis. I see all these bridges, and then you have to go to the CADA to do screening. In the CADA, you do HIV screening to have an instant test. So there is still a lot of work when you have patients lost in follow-up. You forget to take his phone number, even in anonymous consultations. So there are many. It's much more difficult today than 15 years ago. Fly fishing is not easy. So this is what I wanted to say. I'm not talking about patients under methadone. We agree. We still have a lot of work to do. Second burning question. Thank you, Xavier Agnig. I'm a family doctor in Gagny. I want to talk about family doctors. I agree with the objectives we just heard to reach the objective of elimination, screening strategies, test and treat, that we must implement in the same place. For general medicine, there are two priorities. The family doctor should be able to prescribe to any patient a screening, at least one screening in his life. We're not there yet. This is something that we must have. And the second thing is that many patients want to have checkups for fatigues, and when a patient asks for a checkup, we should take advantage of that to include hepatitis HCV screening. Okay, our big chief is here, and we have to clear the floor for the next session. Thank you.